So I think we agree that surgery and cryoablation are the preferred treatment methods for Favas. However, the evidence of these methods, I think, still is a bit limited, especially what is published in the literature. So I would like to present two Fava cases, and I would also like to discuss other possible treatment options for these challenging lesions. So the first patient is a 39-year-old male who reported right calf pain since childhood. And imaging in 2013 showed a diffuse vascular malformation infiltrating calf muscles, and he was at that time diagnosed with a venous malformation. He was actually treated primarily with the surgery in 2013 with partial resection of the gastrocnemius muscle, however, without any significant improvement of his symptoms. And we can take a closer look at the images. You see this extensive diffuse vascular malformation extending into the medial gastrocnemius muscle and the soleus muscle, and also you see the dilated draining veins subcutaneously and also fat infiltration in the muscle. So it's quite clear that this is a Fava, I think, and not a venous malformation. And you can see in this clinical photo quite extensive swelling of the right lower leg. So between 2013 and 2020, he was treated multiple times with endovascular treatments, and quite interestingly, we observed with arteriography multiple micro-AV fistulas, which you may see in this image to the right, with quite rapid filling of the draining dilated veins. So endovascular treatment for this patient included both sclerotherapy of the veins and also embolization of the AV fistulas. And he reported the effect of the treatment. He had less pain and better functional level with this treatment. And this is updated imaging in 2024. You can still see the quite substantial swelling of the right lower leg, and also progression of the muscular atrophy with the medial gastrocnemius muscles being almost totally replaced by adipose tissue. So clinical follow-up just recently, he had a D-dimer of 2.2 and he was considered for anticoagulation therapy. However, he reported no pain at all since summer 2024, and we could not find any indication for treatment at the moment. So the second patient is a 36-year-old male who reported right calf pain since puberty. MRI in 2014 showed a diffuse vascular malformation, and he was also at that time diagnosed with a venous malformation. He was treated 13 times with sclerotherapy between 2014 and 2017, unfortunately without any effect. You can see in this imaging, it's quite an extensive malformation infiltrating both the medial and lateral gastrocnemius muscles, and also extensive fat infiltration in the muscles, and it's consistent with a Fava, I think. So in 2021, he had a D-dimer of 1.7, and we initiated anticoagulation therapy. But this was actually stopped by the patient due to limited effect, and he also reported some side effects. In 21-22, he was offered surgery and sirolimus treatment, but refused this. We have considered best treatment for this patient, but we have not found any evidence in the literature for this method. And he has now finally accepted sirolimus treatment, which will be initiated soon, I think. And I will also say that in this second patient, we did not observe any AV fistulas like we did in the first patient. So just to summarize briefly, I have presented two Fava patients. The first patient did not respond to surgery, but responded quite well to endovascular treatment, including embolization of the AV fistulas, whereas the second patient did not respond to endovascular treatment at all, but he refused surgical treatment. And based on this, I would like to have some points for discussion. First, I quite often hear that endovascular treatment is contraindicated for these patients. So is this correct, or may endovascular treatment still have a role for patients not responding to surgery or patients that refuses surgery? Anticoagulation therapy may play a role for patients with pain and elevated D-dimer. We know that Fava is associated with PIK3CA mutations. Could sirolimus have a role here? But I have only found actually around 10 published cases for this. So the evidence of this is still, I think, quite limited. And lastly, could best be a potential treatment for these lesions. And I would also like to say we have not cryoablation available yet in our institution. Thanks.
Thank you very much. Are there questions from the floor? Yes, in the right.
Nico Simonpää from Helsinki University Hospital. Thanks for the presentation. I'm sure that the first patient wasn't the Parkes-Weber patient because he had fistulas and hemimegaly of the leg. Looked a lot like.
I'm quite sure it's a Fava, but we can discuss. We don't have the genetics for these patients, but good point.
I have a small question in the meantime. The micro-AV fistula that you're describing in this case, do you think they are part of the primary lesion or secondary to some kind of a local venous thrombosis inside the lesion? What is your opinion on it?
It's a good question. I know there are publications that thrombotic events may create like arterial supply to the veins, and to be honest, I don't know.
You haven't observed a big thrombosis in those patients, right? Or there was a history of venous thrombosis of those affected legs. In the first patient you presented, the patient had a thrombosis at some point or not? Not documented.
Not documented.
Okay.
The D-dimer was elevated, so I guess there is some kind of thrombosis.
Not just big thrombosis that was seen clinically or something. Okay, thank you. Next question. Okay.
I'm Jenny, and I'm from Italy. I haven't a very question because firstly, thank you all for what you do. I am a patient with Fava, and I'd like to share my experience if it can be useful for you. I've been diagnosed with Fava 3 years ago, and doctors detected a PIK3CA mutation through a muscle biopsy. But I was born with clubfoot, overground foot, and left lower limb and macrodactyly. I've been described like an unusual case of Fava syndrome because the DCS progressed very slowly over the years, in which I practiced sport as an Olympic professional paracyclist until 30 years old. After stopping competitive sport, I've seen a relatively rapid progression of muscle atrophy with fatty and fibrous infiltration in most of muscles of my left lower limb, deltoid muscle, and excesses of veins in my hands. So I'm taking alpelisib since the January 2024, and I'm doing sport again, para-swimming, in order to fight the DCS progression. The side effects of alpelisib improved in time, and now my MRIs are stable. I'm sure that sport helped me. Maybe sport practiced since I was a child. I didn't need surgery, cryoablation, stereotherapy, and I feel lucky for this. I'm sure that sport changed and saved my life and taught me to accept myself and love my life. Now I'm working on research because I am a PhD student in adapted physical activity and process syndromes, and this is my project, my pilot study that I'm starting in order to evaluate, and I hope to show the positive impact of an adapted physical activity in health-related quality of life and clinical and psychological outcomes in people with this syndrome. So one day, I hope we will be able to consider and mention physical activity as one of the conservative treatments. Thank you.
Denise Adams from TOP. I just want to say that I do think that mTOR inhibitors work. I think they're reserved to the complicated patients. When I was in Boston, we sort of had a team with Raja, Sam, and I, and we saw the patient together and decided which we thought was best. And sometimes we would do sirolimus before Sam did surgery, and then we would actually continue sirolimus afterwards. So we have experience with that and also with the PIK3CA inhibitors. So I think it just makes us want to publish that information, so we'll take that and hopefully get more published.
Michel Lafayette.
Yes. I remind you I am not a radiologist, but I have questions about the diagnosis of these cases, and one of the previous paper, you showed lesions that are developed in the muscle, but also largely in the subcutaneous tissue, and also were diagnosed venous malformation at the beginning. What are your arguments to diagnose them Fava now? And there was one case developed only in the previous paper, seemed to be developed only in the subcutaneous tissue. Can Fava be in the subcutaneous tissue? Maybe we have to change the definition, but for me, Fava is an intramuscular lesion that may extend around the muscle, but not at such input. Thank you.
There are probably people in the audience that can answer this better than me, but for the available publications on this, I think I've seen that it may be both in muscles and crossing the fascia into the subcutaneous tissue, but that's my opinion. Yeah.
Thank you. We'll take one last question.
On the MRI, where you showed that the whole medial gastrocnemius is involved in full cross-section, and we talked about doing tendon lengthenings, I think you should give consideration to excising that muscle, because the whole gastroc, we take it out for plastic surgery to reconstruct things. You're not losing any function because it's not working. And if you leave it there, the other muscles are working against this fibrosed thing, and I think by taking it out, you improve the function of the other muscle, you allow those to exercise. So you should give consideration to removing the muscle when it's completely involved.
So you
there's other tissues.
You would do that even though he has no pain at the moment?
Oh, if he's got no pain, but if he's tight, if he's needing a tendon, I would take it out, but I'd certainly give consideration.
Thank you.
Okay, I think we have to stop there. Thank you very much. And we go to the last presentation. It's given by Dr. Mohammed Amane from Boston Children's Hospital, arteriovenous shunting in a case of Fava and Bros. Welcome.